Good morning. Welcome to Chapter 23, Endocrine Emergencies. The endocrine system influences almost every cell, organ, and function in the body. Patients with an endocrine disorder often have a broad range of signs and symptoms. A thorough assessment and immediate treatment is required to prevent life-threatening emergencies. So these do happen. A lot of folks have diabetes or other related type of endocrine type of emergencies, and we need to be able to recognize those signs and symptoms right away. All right, so the endocrine system, what's it responsible for? What's the anatomy and pathology? The endocrine system is responsible for all the control and regulations of all the systems in the body. Disease occurs when normal cell signaling is interrupted. Some of the components of the endocrine system, you have major components with the endocrine system, which include the hypothalamus, the pineal gland, the thyroid gland, the thymus gland, the parathyroid gland, and adrenal glands, the pancreas and the gonads. And also, the hormones are chemical messengers that are secreted into the bloodstream by the endocrine glands. The hormones circulate throughout the body and target organs to maintain homeostasis. The hypothalamus. It is a small region of the brain that contains several control centers for the body functions and emotions. It is the primary link between the endocrine and the nervous systems. It also produces regulatory hormones controlling the release of hormones by the pituitary gland. The hypothalamus and pituitary gland are intimately related through the vascular system. All right, so the pituitary gland. 6 hormones are secreted by the pituitary gland, which control the activity of other endocrine glands. These are known as tropic hormones. Example, adrenocorticotropic hormone, which is our growth hormone. Okay. 2 other hormones are controlled that control other body functions, ADH and oxytocin. The thyroid gland. The thyroid hormones affect metabolism and are secreted in response to stimulation of the thyroid gland by the anterior pituitary gland. It secretes thyroxine when the body's metabolic rate decreases, the body's major metabolic hormone. It stimulates energy and production in cells. It cannot be produced without proper levels of iodine intake. The lack of thyroxine diminishes the physical and mental growth of any human. Its production is regulated by negative feedback mechanisms that tell it when the energy is getting low, when the iodine is getting low, and when we need to increase them. All right, so continuing with the thyroid gland, it also secretes calcitonin, which helps maintain calcium levels in the blood. It stimulates bone-building cells to absorb excess calcium. It also stimulates kidneys to absorb and excrete excess calcium as well. The parathyroid glands, okay, they assist in the regulation of calcium as well. The parathyroid hormone, or PTH, acts as an antagonist to calcitonin. It is secreted when calcium levels are low. Okay, it stimulates bone dissolving cells to break down bone and release calcium into the bloodstream. It decreases the amount of calcium also released in the urine as well. All right, so the thymus gland helps the immune system. It helps it to identify and destroy foreign intruders. Lets it know when one of these little boogers are in there and it's, going to cause us a problem. So it stimulates the immune system to help to identify it and to destroy it. All right, so the pancreas, wonderful little digestive gland. It's a digestive gland. It considers both the endocrine gland and the exocrine gland, so it's both. The exocrine component secretes enzymes, digestive enzymes specifically, into the duodenum via the pancreatic duct. So here is the pancreatic duct here, okay? All right, the pancreatic duct is here. This is the islet of Langerhans, cells that secrete the actual hormones itself, and this is the duct. And so the islets of Langerhans cells, they secrete hormone into the blood vessels and circulate it out. So it's both endocrine and exocrine. Let's say, so continuing with the pancreas, as far as the endocrine component is concerned, it comprises of the islets of Langerhans. It's cell groups within the pancreas that act like an organ within an organ. Alpha cells secrete glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. So let's go over that again. Let's just remember. All right, so your alpha, you just somehow remember this, guys, because these are definitely test questions. Alpha cells secrete glucagon, which helps us in our ATP production, which helps us with energy. It's another form of sugar. Beta cells secrete insulin. Insulin is our transporter of sugar. Okay, it transports it in the cells. And delta cells secrete somatostatin. All right, so when blood glucose levels fall, glucagon is secreted to raise it. It stimulates the liver to change glycogen into sugar and secrete into the bloodstream. When blood glucose levels rises, insulin is secreted. And insulin, like we talked about earlier, is the transporter of glucose within the cell. And then it stimulates the liver as well to take in more glucose, and store it as glycogen for later use. The only hormone that decreases blood glucose levels, it is the only one, because it will prevent it from transporting it. If you have too little, then there's not that much that's being transported to the cell. Okay, so adrenal glands. Adrenal glands are located on each side of the body on the superior aspect of each kidney. It is divided into two distinct sections, the adrenal cortex, the adrenal medulla, and the adrenal cortex completely surrounds the inner adrenal medulla. It secretes aldosterone in response to a drop in blood pressure, which decreases in sodium or increases in potassium. It also stimulates the kidneys to reabsorb sodium from the urine and excrete potassium. When stimulated by the hypothalamus, the adrenal medulla secretes small amounts of norepinephrine and large amounts of epinephrine. Norepinephrine raises the blood pressure by causing contraction of the smooth muscle that lines the arterioles and the relaxation of the smooth muscles that lines the bronchioles. Epinephrine stimulates the sympathetic nervous system, specifically the receptors, and stimulates the liver to convert glycogen to glucose for use as energy in the cells. What this does, it results in increased levels of oxygen and glucose in the blood and faster circulation of the blood to the brain and heart muscles. This all happens at a time that we really, really need it, such as our fight or flight, um, you know, responses in some kind of event that we need to either fight or run, one or the other. All right, so the gonads. Their primary function is to promote sexual maturation and fulfill the reproductive needs. Testes are in men, they produce hormones called androgens. The regulation changes or they regulative changes associated with puberty. Most important is the testosterone. So, ovaries in women, they secrete hormones, estrogen and progesterone, those two hormones. Estrogen signals the anterior pituitary gland to secrete luteinizing hormone, or LH, when an egg is developed in the ovarian follicle. Both assist in the regulation of the menstrual cycle. At puberty, estrogen supports the development of secondary sex characteristics. Progesterone, just the opposite, it prepares the uterus for implantation of the fertilized egg. So, patient assessment. How do we assess patients, and what are things that we are looking for patients that have endocrine emergencies? They tend not to they tend to affect many different organ systems, so don't take them lightly. So obviously you've seen hazards, you've seen size up, follow standard precautions. Really check the home for medications. Do they take anything that manages their thyroid? Do they take anything that manages, their insulin production, those kind of things? Or, not necessarily in production, or even do they take insulin? So do they take any medications for diabetes? Do they take any medications for their thyroid? Right, so primary assessment, obviously, you're managing all your life threats, form your general impression. Look for your signs and symptoms. They all depend on the affected hormone, okay? Is the patient alert? Diaphoresis definitely is a sign of severe distress in a patient that has some kind of hormonal emergency or endocrine emergency, but it's also a good indicator that we're working on, going into shock as well for any patient. So check for signs and symptoms of specific conditions, the buffalo hump or the moon face. These are conditions that are signs, buffalo hump or moon face and acne are signs of Cushing syndrome. Mottled skin is also associated with pancreatitis. Enlarged or abnormal body parts may occur with the following. You may get edema with syndrome of inappropriate antidiuretic hormones, SIADH, that's symptoms, inappropriate antidiuretic hormones. Otherwise, they're taking some kind of antidiuretic that's creating them problems. Anasarca with myxedemia coma, okay. Underweight or overweight may also indicate endocrine dysfunction, such as hypothyroidism, hyperthyroidism, diabetes. Also, exophthalmos is present in Graves' disease. Also, abnormal development may also be present with children with pantopopulopituitarism. So otherwise, their pituitary gland is creating some different problems. So that's interesting to look up. That's quite a bit to say there. All right. So airway and breathing, ensure the patent airway, investigate abnormal breathing sounds, assess for breathing efforts. Circulation, you're going to be assessing skin color, moisture, and temperature. Get their blood pressure right away. Pale, cool, moist skin may be the sign of shock, hypoglycemia. Hot, dry skin may be a sign of fever, hyperglycemia. IV fluid administration or blood replenishment may be necessary in these patients. Transport decisions, many patients should be transported to a specialty facility, one that can handle their endocrine emergency. Provide rapid transport to the closest facility, especially if this is a child, because sometimes these things do happen. All right, so history taking, especially useful in the diabetic patients. Consider the patient's signs and symptoms and take any pertinent negatives. If a patient is unresponsive, obtain a blood glucose level, manage any abnormalities appropriate. Obviously, use your sample history, okay, to gather information. Some of the signs and symptoms of endocrine disorders in patients with undiagnosed or poorly managed diabetes include polyphagia, polyuria, polydipsia. Hypothyroidism. The following can occur with hypothyroidism in thyrotoxicosis. Tachycardias, premature ventricular contractions, premature atrial contractions, atrial dysrhythmias, and also ascertain if any allergies prior to administering medications. Because if you got a patient that's in hypothyroid crisis or diabetes, conditions such as DKA or comatose, you're going to need to be careful because you're not going to be able to ascertain those allergies in their decreased level of consciousness states. So document the following: all medications the patient is currently taking, whether the patient has been compliant with the regimen of medicines they're supposed to take, and be sure to ask females of childbearing age about their last menstrual periods. Secondary assessment, obviously you're going to, do your head to toe, begin with a physical exam and observation. Look at their general appearance, position in which the patient is found, identify as many atypical findings as possible. A focused assessment is usually not necessary unless trauma is present. Full body scan is more appropriate. Always manage life threats first. Finer abnormalities will help to determine the treatment, such as the condition of the skin. Cold and clammy skin may indicate that the patient's in shock. Severe hypoglycemia, cold and dry skin may indicate an overdose of sedative drugs, alcohol intoxication. Hot and dry skin suggests hyperglycemia, fever, and possibly heat stroke. All right, so goals with your comatose patients, there's two goals. Determine the patient's level of consciousness and look for the source of the coma. Vital signs, look for hypertension and bradycardia, treat them accordingly. Also be alert for any abnormal respiratory patterns. Look for respiratory related motions. All right, so reassessment, continually reassess the patient, be prepared to manage their airway. If you can get some blood specimens early in patients with diabetes, especially because then you'll get a good sugar level prior to any treatment. So after you turn the patient over, you'll be turning over a patient with elevated sugar levels from your treatment, but yet you'll still have a blood sample of what it was prior to your treatment. So provide emotional support, monitor their cardiac rhythms, and recheck all their vital signs. All right, so emergency medical care. What exactly can we do for our endocrine patients? Well, there's not a whole lot that we can do other than treat any low blood sugars because of the fact that we don't carry hormonal therapy. So, and that would just absolutely be impossible. That'll never be something that we'll do in the field. Well, I should never say never because this crazy world, you never know. But D50 for sure. If they have blood glucose levels that are low, we need to start treating them. Establish your IV, get that little drop of blood on there and see what the blood sugar is and then treat accordingly. Transport for comatose patients, obviously, you may have to intubate them. If you have an unknown patient, making sure they're surviving with a cervical collar at minimal. Not intubated, stable side position, increase intracranial pressure. They may have that going on. Head elevated should be somewhere between 30 and 45 degrees in midline. Keep the mouth and pharynx free of any secretion. So be prepared to suction them out. All right, so metabolic, derangements, okay, is what we call it. Our glucose metabolic derangements is when they have, poor glucose stores. So when we talk about this, endocrine disorders are usually caused by either hypersecretion or insufficient secretions of a gland. Hypersecretions present as overactivity of the organ that regulates by the gland, or organ regulated by the gland. Insufficient secretion of a gland usually presents itself as underactivity of the organ controlled by the gland. So glucose metabolic derangements disorders are caused by dysfunction of the pancreas, okay? It impairs the body's ability to metabolize glucose. Most endocrine emergencies result in the following, okay? And you need to know the degree of the dysfunction or assume the degree of the dysfunction based on these problems. Age and sex of the patient is something that is a contributing factor. Most significant endocrine emergencies, like I said, they result in a compromise of the airway, breathing, and circulation, improper fluid balances, and also deteriorating mental status with abnormal vital signs and abnormal blood glucose levels. Diabetes, it's a group of complex metabolic disorders, okay? They encompass a group of several. Diabetes mellitus, gestational diabetes, hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. So, metabolic disorder in which the body's ability to metabolize simple carbohydrates is impaired. That is diabetes mellitus in a very simple word. Our body's not able to break down simple carbohydrates to make them into sugars or to transport them from one cell to another bloodstream to the cells. So it's characterized by polyphagic increase in, polyphagia, which is an increase in the appetite caused by the inability of the glucose to be transported across the cell membrane. Polydipsia, which is a significant thirst caused by dehydration brought by an increase in diuresis. And then polyuria, which is a passage of large quantities of urine containing glucose. All right, so glucose, our dextrose, along with oxygen, it is the primary fuel for cellular metabolism. It is characterized by the body's inability to sufficiently metabolize glucose. In people with this disease, either the pancreas does not produce enough insulin or the body cells do not respond to the effects of the insulin that is produced. In either case, there is an elevated level of glucose in the blood and glucose in the urine. Glucose builds up and flows out of the body. cells can actually starve for glucose. According to the 2014 National Diabetes Statistics, they report that 29.1 million people in the United States, which is approximately 9.3% of our population, have diabetes. 8.1 million remain undiagnosed. In 2013, diabetes was the seventh leading cause of death in the United States. All right, so this figure shows how glucose is unable to enter the cells in a diabetic patient. Okay, this is slide 36 of 103. All right, so life-altering complications from diabetes includes kidney failure. Diabetes is the principal cause of kidney failure. The glomerula of the kidney becomes sclerotic, causing necrosis of the papillary tissues, nephropathy, also renal failure, which ultimately high levels of blood glucose may result in the decrease of kidney function over time as well. Heart disease or stroke is also one of those side effects. So adults with diabetes are 2 times more likely to die of a heart disease or have a stroke. When diabetes is not properly controlled, lipolysis raises the level of fat in the blood. This is called dyslipidemia. Okay. It increases the risk of atherosclerosis and coronary artery disease quite significantly. Microscopic deterioration of the vessel walls as well, which is microangiopathy, okay, which is a condition in which swelling of the membrane cells restrict the flow of blood to organs and tissue. So ultimately, ischemia develops, which causes necrosis. The central nervous system damage can cause cardiac dysrhythmias as well. Microangiopathy and neuropathy contribute to an increased risk for silent myocardial infarctions. They combine and result in the patient not perceiving common signs of chest pain, pressure, or tightness, often associated with acute myocardial infarction. AMI should always be assumed until proved otherwise, especially in your patients that are diabetic, like we mentioned earlier. They had that generalized neuropathy doesn't allow them to feel the pain like they normally felt. All right, so cerebrovascular disease, stroke, and hypertension, how does that evolve itself with diabetes? Vessels are damaged by the microangiopathy, which characterize cerebrovascular disease and are also associated with an increased incidence of stroke. Peripheral artery disease also impairs circulation to the lower extremities. Hypertension is present in 2 out of 3 persons with diabetes, which can also cause eye damage. In adults, diabetes is the primary cause of new cases of blindness. High glucose levels or high blood glucose levels damage the vessels of the eye. Scar tissue may pull the retina from the eye, which is called retinal detachment. Cataracts form when fructose and sorbitol are deposited on the lens. So it can be definitely a debilitating disease over a long period of time. All right, so other life-altering neuropathy, we touched on this a little bit. This is nerve damage that results ultimately in the loss of sensation and function. It often affects peripheral nerves, causing diminished sensation and function in the extremities. Also, paresthesia and dysesthesia can blunt pain perception, causing ulcers to go unnoticed until they become seriously infected. Then finally, gangrene may develop adjacent tissues due to the poor circulation. Infection may spread to the bone, which can result in an amputation. Many conditions are associated with diabetes can be delayed or prevented with lifestyle changes and continued management. Blood glucose levels are more difficult to control during stress and physical activity. So chronic and acute complications are associated directly with diabetes mellitus. More severe in people who require insulin. But left untreated, diabetes leads to organ system dysfunction, wasting of body tissues, death, severity of complications that correlates with average blood glucose levels, age of onset. There is no cure for diabetes. There is no known cure for diabetes. We can only treat the symptoms. All right, so type 1 diabetes. Its pathophysiology, it is referred to as insulin dependent diabetes, specifically into insulin dependent diabetes mellitus or IDDM. Or it can also be called juvenile diabetes because it generally affects children. Although a heredity predisposition exists, environmental factors may also be a part of the cause. Significantly, the body develops autoantibodies that incorrectly identify the body's own tissues or substances as foreign invaders to be destroyed. Specifically, pancreatic beta cells become more incapable of secreting insulin and regulating intracellular glucose. So insulin must be administered for these patients by injection or with a pump. You have latent autoimmune diabetes in adults, which is a variant type of type 1 diabetes that occurs in adults older than 30 years of age. Strictly dietary control must be observed. Increased activity and alcohol consumption can lead to low blood glucose levels. All right, so the assessment of these patients, we're going to determine whether the patient is compliant with the disease management. That's the biggest thing, with altered mental status, suspected to have low blood glucose levels. Additional chronic conditions may also include renal failure, congestive heart failure, coronary artery disease, hypertension. They also may have vision and hearing impairment. So we need to also look and assess for signs of sores or other infections because they are very susceptible to those. Ask about tingling or numbness or swelling in the extremities, any vision changes, headaches, dizziness, bleeding, sores in the mouth, recent changes in bowel or eating habits. All right, so management, not that difficult. It always requires insulin administered by injection or an insulin pump. Insulin cannot be ingested orally because of the digestive process will render it inactive. Some patients use insulin pumps to treat their disease. It consists of an infusion set, a reservoir for the insulin, and a pump. As you can see, this young lady is wearing an insulin pump on her right side there. And that's what that little deal is, that little doodad right here. There you go. I've seen a few patients with these. They've gotten much, much smaller since this one. They're about the size, if y'all remember, the old pagers, except for maybe y'all don't know pagers, not all of you, but they're fairly small. Okay. All right, so with that infusion pump, it's an alternative to multiple daily injection. The pump is approximately the size of a deck of cards, weighs approximately 3 ounces, and can be worn by a belt or carried in a pocket. Insulin is administered through a catheter under the skin. The pump is often set to deliver a basal amount of insulin continuously throughout the day. Alternatively, the pump can also be set to deliver a bolus of insulin, such as specific times when meal times occur or when blood glucose levels are high. Several types of insulin are available in the United States. You have rapid acting, regular or short acting, intermediate acting, and long acting. All of these differ in the onset of action, duration, and peak time. All right, type 2 diabetes, a little bit different. It's the most common form of diabetes. The blood glucose levels are elevated because the body cannot produce enough insulin. The pancreas actually produces enough insulin, but the body cannot effectively use it. It's a condition known as insulin resistance. In some cases, an abnormal increase in the production of glucose by the liver causes an increase in blood glucose levels. When glucagon levels remain high, excessive amounts of glucose are produced, leading to high blood glucose levels. Metformin is the medication most commonly prescribed for the management of type 2 diabetes. It causes a decrease in glucose production. Approximately 8.5% of the world's population is affected by diabetes, mostly type 2. Approximately 90% of the people with diabetes in the United States have type 2 diabetes. Development is associated with obesity and physical inactivity. Development of the metabolic syndrome is associated with excessive weight, lack of physical activity, and genetic factors. So the assessment on these patients, symptoms may include fatigue, nausea, frequent urination, thirst, unexplained weight loss, blurred vision, frequent infections and slow healing of wounds, being cranky, confused, or shaky, unresponsiveness, seizure. Symptoms generally tend to develop gradually and become noticeable in about the middle age. A small percentage of persons do not display any symptoms whatsoever. So how do we manage this? Management is bottom line weight loss. It helps control disease along with exercise and diet. Food intake must be spread throughout the day and in coordination with daily medications, insulin injections. Oral medications may be used alone or in combination, so it's not so difficult. It's usually controlled with diet and exercise. All right, so this is table 23-1, talks about different oral agents used to treat type 2 diabetes. Here you have the medication class, the function, and some of the examples. All right, so pre-diabetes. Okay, it's related to certain risk of factors associated with type 2. It exists when blood glucose levels or hemoglobin A1C levels are above normal levels, yet not high enough to be diagnosed as diabetes. A1C blood test reveals information regarding the patient's blood glucose levels over the previous 3 months. Affects usually 1 out of 3 U.S. adults, approximately 86 million people, and 90% are unaware of their status. Within about 5 years and with no intervention, 15% to 30% of the people with prediabetes will develop type 2 diabetes. Risk factors, those that are greater than 45 years of age, being overweight, family history of diabetes, being African American, Hispanic, Latino, or American Indian, Pacific Islander, or some Asian American racial or ethnic backgrounds. Gestational diabetes, or having given birth to a baby who weighed more than 9 pounds, and also being physically active fewer than 3 times a week, or interventions affecting 2 specific factors can help prevent or delay onset of type 2 diabetes by about 58%. Losing 5% to 7% of the patient's body weight, getting at least 150 minutes of physical activity per week. All right, so gestational diabetes, this is pregnancy, diabetes, pregnancy related. It's a form of glucose intolerance that occurs during pregnancy. It occurs more often in women who are African American, Hispanic, Latino, and Native American, are obese, or have a family history of diabetes. Increased risk of type 2 diabetes go along with this, and it usually resolves itself before delivery for most women. It's usually diagnosed at the 28th week of gestation and peaks in the 3rd trimester. Hormones are produced by the placenta and may impede the function of insulin. So the condition does not produce birth defects, so there's no worry there. But like I said, it usually goes away somewhere within that 3rd trimester. Assessment of a patient that you may suspect this, the oral glucose tolerance test is used to diagnose gestational diabetes until within about 12 weeks of delivery. The hemoglobin A1C test can also be used during the first pregnancy visit to identify the presence of pre-existing diabetes or prediabetes. Management, stabilizing blood glucose levels as soon as possible, diet modification and exercise, and blood glucose testing. Insulin injections, they may be required, but they're usually not. All right, so hypoglycemia, blood glucose level less than 45 milligrams per deciliter or less. It is a common problem experienced by patients with both type 1 and type 2 diabetes. Patients must closely monitor and intensively control their diabetes to prevent long-term complications. Hypoglycemia is relatively common and can be treated easily. Severe hypoglycemia requires intervention and treatment. All right, so pathophysiology of hypoglycemia. It often results from too much insulin, too little food, or both. The central nervous system tissue depends on glucose for energy. Counter regulations, okay, is the body's natural defensive ability to maintain blood glucose at an appropriate level. It is our normal regulation mechanism that creates homeostasis with our carbohydrates and our energy production. Body's first line of defense okay, reduce insulin and production by the pancreas, increase glucagon produced by or production by the alpha cells. The second line of defense is the secretion of catecholamines, and then the last defense is the stimulation of the autonomic nervous system. Otherwise, it's now going to start making us breathe so we can, faster, so we can blow off, whatever we need to do to retain some of the sugars. Yeah, the last part of the stimulation of it generates signals that allow for the production of counter-regulatory hormones. And it increases the same stimulation, also triggers symptoms of telling the body the blood glucose is low. All right, so continue on with hypoglycemia in patients with type 1 diabetes. The islets of Langerhans do not make insulin. They're told not to. The body's first line of defense against hypoglycemia is lost. Causes of low blood glucose level in a patient with diabetes, elevated level of exogenous insulin from inaccurate dosing, and also intentional overdoses or a mismatch with carbohydrate intake and exogenous insulin intake. Increases uses of glucose, such as during exercises, cause the blood glucose level to drop sharply. In patients with type 2 diabetes, the pancreas can also generate insulin. However, their bodies may be resistant to the effects of insulin. They may not make enough insulin over time to lower blood glucose levels adequately. Also, medications given to treat type 2 diabetes, they act by either stimulating the body's ability to secrete insulin or by improving insulin's actions. They also tend to contribute to hypoglycemia as well. In some patients who have had type 1 diabetes for many years, and to a lesser degree, patients who have had type 2 diabetes for many years may not have a glucagon release from the pancreas in response to hypoglycemia. So therefore, the body is more dependent on epinephrine to overcome the effects of hypoglycemia. Yet, there may be some lack of responsiveness to epinephrine in diabetes as well, such as prolonged disease can also decrease the patient's ability to recognize having low glucose levels or hypoglycemia. Is what we know as hypoglycemia unawareness. Preventing a person from self-treating themselves is the biggest thing that happens in hypoglycemic unawareness. They just don't tell. They can't tell that their blood sugar is getting too low. All right, so our assessment. The patient will tremble, have a rapid pulse rate, sweaty, and feel hungry. If the condition persists, cerebral dysfunction will progress to permanent brain damage. Common signs and symptoms include blood glucose level that's less than 60, hunger, agitation, or irritability or combative behavior that cannot be explained, altered mentation or confusion, nausea, weakness, tachycardia, cool, clammy skin. You can tell that this person is got low blood sugar. They just had no energy. They're very, very altered in their mentation. Their decreased levels of consciousness are going to progress until they become comatose. So additional signs and symptoms: headache, memory loss, incoordination, slurred speech, irritability, dilated pupils, and then this is the biggest thing, seizures and comas. We need to prevent this from happening. All right, so if hypoglycemia develops rapidly, suspect a diabetic patient with bizarre behavior and neurological signs and coma. These are the ones that are really, really on that edge or that cusp. Management immediately, if they're conscious, we're going to use glucose orally. If they're unconscious, we can administer glucose. Rule out hypoglycemia in a field glucose test. We're going to use our glucometers to see what we've got going on. Administer tablets if the patient's alert and able to swallow. If the patient has altered LOC or difficult airway, aspiration could very, very well happen. So be careful. Make sure you suction their airway out plentiful. A patient with decreased LOC and obtaining an IV line may be difficult. You may have to administer glucagon IM. That is a life-saving medication that if you can't get the IV, especially in patients who are obese, that maybe you just can't get a good IV because dextrose is the only thing that's going to save them. Now, you can't go IO, so if you have that ability, you can do that as well. All right, so hyperglycemic diabetic ketoacidosis. Okay, the pathophysiology of this is hyperglycemia is the problem. We have too much sugar. Early signs include frequent or excessive thirst and urination. It occurs when the blood glucose levels exceed 120 milligrams per deciliter. In patients with diabetes, physicians try to maintain glucose levels less than 160. All of these variations can be caused by excessive food intake, insufficient amounts of insulin production or doses, infection or illnesses, injury, surgery, emotional distress. Onset of these problems can be very rapid. They can be within minutes or gradually over hours to days. Other causes of hyperglycemia, the dawn phenomenon, which occurs in the hours before waking. As the body prepares for a new day, it releases hormones such as cortisol and catecholamines. These hormones trigger a release of glucose from the liver, resulting in hyperglycemia. The Somogy effect is a phenomenon that occurs when a low blood glucose level generates a release of hormones that initiate a release of glucose from the liver, causing hyperglycemia. Some patients with type 2 diabetes can go undiagnosed for several years. Repeated episodes of hyperglycemia will eventually cause several physiological changes that have detrimental long-term effects. Hyperglycemia puts undue strain on the cardiovascular system, the kidneys, and other end organs that are sensitive to the increase of serum viscosity and subsequent pressures exerted by the thicker serum of the blood. The eventual result is an increased incidence of disorders such as renal failure, congestive heart failure, retinopathy, coronary artery disease, and neuropathy. When serum glucose levels rise above tolerable levels, other physiological changes occurs. You start getting the diabetic ketoacidosis. This is when the blood glucose levels are greater than approximately 350 milligrams per deciliter. Then you get hyperosmolar hyperglycemic syndrome, or HHS. It's when blood glucose levels are greater than approximately 600 milligrams per deciliter. Wow. I've seen it as high as 2100. It was at Patrick Air Force Base on a patient. When you walked into the emergency room, you could smell this overwhelming smell of juicy fruit in the air. That's what diabetic ketoacidosis smells like, because they're trying to blow off all the ketones. She had Kussmaul respirations, and she was just trying to get rid of all those ketones or all that excessive sugar. Untreated hyperglycemia will progress to diabetic ketoacidosis. It's associated predominantly with type 1 diabetes. It is a life-threatening condition. It occurs when certain acids accumulate in the body because the insulin is not available. Common causes include infection, injury, alcohol use, emotional disorders or emotional discord, illness, stroke, or myocardial infarction. These patients tend to be teenagers and young adults. All right, so pathophysiology. Rising blood glucose levels and massive osmotic diuresis. Otherwise, they're peeing like crazy. Osmotic diuresis and vomiting also cause dehydration and even shock. And DKA, the deficiency of insulin, prevents cells from taking up extra glucose. And because the body cannot use the glucose, it uses fat. The metabolism of fat generates acids and ketones as waste products. And because glucose must be excreted in the urine in solution, the body loses excessive amounts of water and electrolytes, specifically sodium and potassium, which may lead to disturbances in water balance and acid-base balance. So large quantities of ketone bodies in the bloodstream causes a decrease in the blood's pH and results in acidosis. In patients with type 2 diabetes, DKA is rare because the insulin is still present, at least early on in their diabetes history. All right, so our assessment. Signs and symptoms of hypoglycemia and hyperglycemia can be very similar. Hypoglycemia signs and symptoms can include blurred vision, polyuria, which is our excessive urine output, polydyspia, which is excessive thirst, and polyphagia, excessive eating. Now, orthostatic syncope occurs as well in these patients because of the fluid balance changes, and then they usually are resulting of also frequent infections, and a lot of these patients will have skin ulcerations. Hyperglycemia usually progresses slowly, with level of consciousness deteriorating gradually, usually over a period of about 12 to 48 hours. The load of glucose in the kidneys results in glucose spilling into the urine, causing the body to become hyperosmotic. As the kidneys remove the excess glucose, water is removed via increased urination, leading to dehydration. Kidneys can also help to clear up the ketone bodies from the blood as well. But the patient's going to lose excessive amounts of sodium, potassium, and phosphates in the urine. This is a combination of effects that leads to both dehydration and metabolic acidosis associated with all the electrolyte imbalances that are going on with the body. Ultimately, the resulting signs and symptoms manifest themselves as the following: polyuria, polydipsia, polyphagia, and then also nausea, vomiting, tachycardia, deep rapid respirations, which we call the Kussmaul respirations. They'll have warm, dry skin and dry mucous membranes, and like I said earlier, they'll have a really strong fruity odor of ketones on their breath. I swear it smells like juicy fruit. You can get you some juicy fruit gum, and you'll say, "Whoa, that's what it smells like." They also may complain of abdominal pain, hypertension, and sometimes fever. Patients may exhibit thin or dehydrated appearance, warm, dry skin, orthostatic hypotension, supine hypertension, fatigue, altered mental status, and if a patient is in coma state, look for head injury, stroke, or drug overdoses. All right, so this table 23-3, it shows a comparison of the hypoglycemia and hyperglycemia. Management of any of these patients, especially your patients in diabetic ketoacidosis, insulin therapy. Okay, that's about all you can do for them. Now we can flood them with a lot of fluids, specifically saline. That's going to help, with patients. But more so, you need to remember the following, and please be careful and remember this. If you have a patient that's in acute diabetic ketoacidosis and they're hypotensive, give them isotonic fluids. Monitor their cardiac rhythm. If they have sharply peaked T waves, it may require administration of sodium bicarbonate. The sine wave may also require administration of calcium chloride or gluconate. These are very, very important things to remember because, when glucose level is more than 250 milligrams per deciliter, this causes, in most instances, insulin therapy should be delivered in these kind of patients. Now, as you move further, the vomiting and all of the dehydration that goes along with it, you're going to need to re-infuse these folks with an IV of normal saline, at least within the first hour, or as suggested by protocol. Now, if that patient is also hypertensive, you need to give them rapid boluses to be ensure that we keep a systolic pressure that is 80 millimeters or higher, and then slowly infuse after that. Monitor for pulmonary edema because some of these patients can have congestive heart failure as well. As we mentioned about the T waves, it may indicate dangerous high levels of potassium. So that's what we're working on here with these kind of patients. So if you have too much potassium, you may require to give them sodium bicarbonate. As the potassium levels rise, the QRS complex will widen and tend to blend with the T wave, developing what we call a sine wave. So the QRS and the T wave are beginning to come together, and we call it a sine wave. This is a very, very specific moment. Okay, so, and then the patient may also become bradycardic on this. Management with calcium chloride or gluconate may be indicated for these kind of patients. Now, they also may become hypomagnesic as well. That commonly results in a loss of the magnesium to the urine. It is electrolyte imbalance that can worsen with patients that have vomiting. Can also cause altercations in mental status as well, and also induce other electrolyte abnormalities. Eventually, it will lead to fatal cardiac dysrhythmias. Magnesium deficiency from DKA is generally not treated in the pre-hospital setting. Complications of DKA are frequently associated with its management. Infusion of insulin may also lead to hypoglycemia. So hypokalemia may result when insulin shifts potassium back into the cells. Cerebral edema may also occur if blood glucose levels shift too far or too rapidly, which is more prevalent in the pediatric patients. I just tell you folks, remember, if you end up seeing the sine wave, this is a national registry type of scenario that the patients require the administration of calcium chloride or gluconate, and to be able to correct this problem, especially with the excessive amount of potassium and the use of sodium bicarbonate. All right, so pathophysiology, hyperosmolar hyperglycemic syndrome, also called HONK. I don't know who came up with that one, but honk, right? Uh, it's a metabolic derangement that occurs principally in patients with type 2 diabetes. The term hyperosmolarity describes the concentration of blood resulting from relative dehydration. Key signs on these particular patients include hyperglycemia, altered mental status, drowsiness, and lethargy. Also severe dehydration, thirst, and dark urine. You'll see really dark urine, especially from the dehydration. Visual or sensory deficits, partial paralysis, or muscle weakness, also in seizures as well. All right, so continue on here. Few patients present with comatose, fewer than about 20%. Most have severe dehydration and focal or global neurological deficits. Clinical manifestations and features of HHS and HONK and DKA tend to overlap. So often it develops in patients with diabetes who have secondary illnesses that lead to reduced fluid intake, such as patients with urinary tract infections. It really screws with their endocrine system. So keep that in mind when you have somebody that has signs and symptoms of urinary tract infections. All right, so assessment on these patients, not that big a deal. Patients who do not experience, usually do not experience ketoacidosis, and the ones that do, the onset can take up to 2 to 3 weeks. Approximately 30% do not have a prior diagnosis of diabetes. Usually this is a stress response that tends to increase hormones that favor elevated glucose levels and that often counter the effects of insulin, including cortisol, catecholamines, glucagon, and many others. Neurological changes may also be found, including drowsiness, lethargy, delirium and coma, focal or generalized seizures. Also visual disturbances, hemiparesis, and sensory deficits. All right, this particular chart shows HHS and the comparison of hyperglycemic conditions. It gives you HONK versus HHS and diabetic ketoacidosis. So, management. Assess their dehydration and altered mental status. Manage their airway, boluses of fluid is appropriate for nearly all the patients that are clinically dehydrated. Pancreatitis, pathophysiology of this guy. It's an inflammation of the pancreas. Acute pancreatitis is a medical emergency. It can lead to dehydration and hypotension. Approximately 60 to 80% of these cases are caused by gallstones, chronic alcohol abuse, and other potential causes, which include certain medications, trauma, pancreatic cancer, also genetic predisposition, and chronic pancreatitis is also a progressive type of disease. Usually, it eventually leads to the loss of all endocrine and exocrine functions, and it often causes chronic pain. It's often diagnosed by computed tomography or CT scan. All right, so the assessment of these patients, acute pancreatitis may present with flank or epigastric pain that worsens when the patient is supine. Tachycardia, fever, jaundice is typically an attack that results of a large, heavy meal or excessive drinking. Symptoms include nausea and vomiting, abdominal distension, and muscle spasms. Less frequently, necrosis and organ failure. Laboratory diagnostics will include determinations of serum amylase, lipase, and trypsin. Management of these patients, there's not a whole lot, it's just supportive care. Patients should not eat until nausea has subsided. Patients should be transported. Patient management is not always effective but can be considered. For patients with chronic pancreatitis, lifestyle changes are absolutely critical. Analgesics are used to control pain. Pancreatic enzymes also assist with steatorrhea and also malabsorption of the pancreas. Surgical intervention may be considered, but it's usually not high on the list. Patients should be monitored for pancreatic cancer. All right, so adrenal insufficiency, its pathophysiology is when it's characterized by a decrease of function in the adrenal cortex and consequent underproduction of cortisol and aldosterone. It results in the weakness, dehydration, and inability to maintain adequate blood pressure. Cortisol's primary role is to assist with the response to stress. but it also helps to maintain blood pressure and cardiovascular function. It regulates the metabolism of carbohydrates and proteins and fats, and it modulates glucose levels by balancing the effects of insulin. It also slows the inflammatory support as well, inflammatory support, and also when you have abnormal adrenal cortical function, it produces abnormalities in the metabolism of carbohydrates and proteins, and also disturbances in salt and water metabolism. Usually well tolerated, but may be complicated by factors such as infection or stress. And it affects about 4 persons per 100,000 in the United States. Right, so primary adrenal insufficiency, we call that Addison's disease. You may have heard of that before. Its pathophysiology is because it's caused by atrophy or destruction of both the adrenal glands. Ultimately, it leads to deficiency of all of the steroid hormones in these glands and what they produce. It is a rare disease, only about 1 per 100,000 persons in the United States. Usually it's the result of some idiopathic atrophy, such as the immune system creates antibodies that attack and destroy the adrenal cortex. It only occurs when at least 90% of the adrenal cortex has been destroyed. Less commonly, it's caused by tuberculosis, bacterial or viral or fungal infections, adrenal hemorrhage, or cancer of the adrenal glands. Some of the assessments which you can find for Addison's disease, some of the signs and symptoms: unexplained weight loss, fatigue, vomiting, diarrhea, anorexia, people that crave salt, muscle and joint pain, abdominal pain, postural dizziness, increased pigmentation in the exterior surfaces of the palmar creases, and also oral mucosa. You can see it in this particular diagram, right, or this photograph here. The patient on the right has the abnormal pigmentations. Right. Right, so the body improperly regulates sodium, potassium, and water in Addison disease, especially within the body fluids. So the blood volume and blood pressure fall, sodium concentration of blood falls, blood potassium rises as well, creates all kinds of deficiencies, and also malfeasance or misdistribution of potassium and calcium. So it can cause ultimately, cardiac dysrhythmias along with that. So management for us, basically you're assessing managing the ABCs. If needed, use a coma protocol of glucose, thiamine, and naloxone. Initiate aggressive fluid replacement using 5% dextrose and normal saline. Hydrocortisone 100 milligrams IV is indicated in the acute management of a crisis, but usually most pre-hospital providers don't carry that. All right, so secondary adrenal insufficiency, its pathophysiology is that it's relatively common. It's characterized by a lack of adrenocortical hormone, or ACTH, secretion from the pituitary gland, which, ACTH, as we discussed earlier, stimulates the adrenal cortex to manufacture and secrete cortisol. It may also occur in patients who abruptly stop taking corticosteroids. Corticosteroid treatment suppresses the natural cortical production of cortisol. All right, so the assessment of these patients, signs and symptoms may also appear suddenly as Addison's crisis. It may be triggered by an acute exacerbation of chronic insufficiency. Most common cause is corticosteroid withdrawal. In about 25% of the patients first experience symptoms during Addison crisis, their chief clinical manifestation is shock. So symptoms may also include weakness, lethargy, confusion or loss of consciousness, low blood pressure, elevated temperature, and severe pain in the lower back, legs, or abdomen. Also severe vomiting and diarrhea as well. Right, so how do we manage these patients? Unrecognized, untreated episodes of this could be fatal for secondary adrenal insufficiency. So we need to maintain their airway, breathing, and circulation. Begin rehydration as quickly as possible. So give them fluids to maintain systolic blood pressures and correcting electrolyte and any acid-base abnormalities. So that 1 liter of 9% normal saline may absolutely, change things around very quickly on these patients. If the patient is hypotensive, also administer a normal saline bolus at 20 cc's per kilogram. Check the patient's glucose level, administer 25 to 50 grams of D50 to correct any hypoglycemia. D5 normal saline is the preferred IV fluid, but we don't carry that normally in the field. Make sure to monitor their cardiac rhythms as well, because their electrolyte disturbances may manifest themselves as cardiac dysrhythmias. Cushing's syndrome, we talked about that earlier, especially in children. Pathophysiology and assessment of this is pretty simple. It's caused by excessive amounts of cortisol production by the adrenal glands. Examples: tumors of the pituitary gland or adrenal cortex. Also, excessive use of cortisol or other stimular corticosteroid hormones. Another example for the treatment of the life-threatening illnesses, such as characteristic changes in metabolism of carbohydrate, proteins, and fats are disturbed. Okay, they change. Blood glucose levels rises, and then what subsequently occurs, protein synthesis is impaired. So after the impairment of the protein synthesis, body proteins are broken down, and it leads to the loss of muscle fibers and muscle weaknesses. Bones become weaker and also more susceptible to fracture and Cushing syndrome as well. So assessment of this. Other common signs and symptoms include weakness and fatigue, depression, and mood. They become day and night. They can swing from one way to the other. Increased thirst and urination, high blood glucose levels, weight gain. You may have, especially in the abdomen or in the face. That's where that moon face comes from. Also the neck, upper back, which is we call the buffalo hump. Thinning of the skin. They may have easy bruising, okay, pink or purple stretch marks or striata, which increases in their acne, facial hair growth, or scalp hair loss in women, and cessation of menstrual periods. You may also get darkening of the skin, which is called anthocenosis on the neck, obesity, and poor growth in height of children. So Cushing syndrome is not related to our trauma assessment Cushing syndrome. This is completely different and has to do with the endocrine system. So management, basically assess and manage their ABCs. Pre-hospital treatment is always supportive. Make sure that we're looking at their glucose levels and administer D50 as necessary. All right, so adrenal gland tumors, phenocryptoma, it's a rare condition in which the tumor, usually in the medulla, causes an excessive release of hormones to include epinephrine and norepinephrine. Less than 10% are malignant. Most common of this is in young adults around mid or adult life. Creates a combination of syndromes that are frequent but sporadic is common. It also may increase in frequency, duration, and severity. All right, so growth hormone pathologies, very specifically, you may have anterior pituitary gland, which, it ultimately secretes our growth hormone. You may have problems associated with that growth hormone secretion to include both oversecretion and also undersecretion. Usually these are rare. It's usually a result of some kind of tumor. Oversecretion results in acromegaly, which is a condition that usually is diagnosed in young adulthood. It results in giganticism and also abnormally large hands and face, as well as facial characteristics. Undersecretion is rare and is characterized by the delay in developmental and growth. So ultimately, the lack of treatment may lead to dwarfism. Okay, so hypothyroidism, this is a great little chart, 23-4, that gives you a good layout on the differentialities of the cardiovascular effects, the metabolic effects, neurovascular, mental, emotional, so on and so forth. So it really gives you a lot of good information. Approximately about 20 million Americans have some kind of thyroid disorder. Graves' disease is the most common type of hyperthyroidism, and it increases metabolism. Hypothyroidism often is the result of an autoimmune disease. It decreases the metabolism. Patients are likely to require supplemental oxygen, especially the ones that are hypothyroid metabolic activity, because it increases oxygen demands. Also, hypothyroid conditions may lead to diminished respiratory effort as well. Graves' disease is the most common cause of hypothyroidism. It is 10 times more common in women. It tends to follow a chronic course of remission and relapse. It may be fatal if it's not treated. It is an autoimmune disorder in which the thyroid gland hypertrophies or enlarges as its activity increases. It produces a visible mass in the anterior portion of the neck. Basically, it's overactive glands that secrete an excessive amount of thyroxine. Other signs and symptoms include increased appetite with marked weight loss, polydipsia, exophthalmos, preorbital myxedemia, which is an orange peel kind of appearance, and also non-pitting edema of the skin on the anterior part of the leg below the knee. Hashimoto disease, rare, but it does occur. It's another cause of hypothyroidism. It's more common in women. It results in the infiltration of T lymphocytes and plasma cells. It is an autoimmune disorder that affects TSH or thyroid stimulating hormone receptors. Hypothyroidism follows that after antibodies destroy the follicles themselves. Myxedemia, coma, this is adult hypothyroidism. If a supply of the thyroid hormones becomes inadequate, what happens is that organ tissues do not grow or mature. Therefore, energy production declines and actions of other hormones are definitely affected. So adult hypothyroidism is called myxedemia. Patients often have local accumulations of mucinous material on the skin. It's manifested by the slowing of metabolic processes, as you can see over here in this photograph on the right. Symptom severity is consistent with the degree of deficiency. It may include fatigue, feeling cold, weight gain, dry skin, and sleepiness. So basically, the continuance of dropping of the hormone levels may lead to the myxedemia coma. It is accompanied by physiological decompensation that leads to peripheral vasoconstriction. It's often precipitated, and triggers include infection, especially pulmonary and urinary tract infections, exposure to cold, trauma, surgery, certain medications, and is a hallmark of deterioration of mental status. Most causes occur during the winter in women that are older than 60 years. It is consistent finding is hypothermia in these patients, which you'll also have an absence of fever, and the presence of infection is very, very common. Hypothyroidism decreases intestinal motility, so it's associated with a decrease in metabolic rate. Myxedemia coma is a metabolic and cardiovascular emergency. If it's not diagnosed and treated immediately, the mortality rates are about 40%. Management, supplemental oxygen for hypoxia. You may have to intubate and ventilate as indicated. Monitor their cardiac status. Make sure that you're doing passive rewarming for patients that are hypothermic, and avoid any sedatives, narcotics, or any anesthetics. All right, thyroxetosis. It is a toxic condition caused by excessive levels of circulating thyroid hormone. It may be caused by hyperthyroidism, goiters, autoimmune disorders, thyroid cancer. We also relatively call this as a thyroid storm. It is very, very rare. It doesn't happen very often, but it is definitely a life-threatening condition. It may occur in patients with thyroid oxytosis and is usually triggered by a stressful event. Also, if there's an increased volume of thyroid hormones in the circulation system. The patients may present with normal signs and symptoms of hyperthyroidism, as well as fever, tachycardia, nausea, vomiting, also altered mental status and heart failure. So what can we do about it? Increased parathyroid hormone levels are what we call hypoparathyroidism. It's marked by increased parathyroid hormone levels, which result in increased levels of blood calcium. Also relates to hypercalcemia, decreased phosphate blood levels as well. Primary causes result from the gland itself. Secondary causes elsewhere in the body. The most common cause is benign neoplasia in the gland, or what we call an adenoma. All right, so what can we do? Signs and symptoms: fatigue, weakness, nausea, vomiting, confusion, pathologic fracture secondary to the thinning of the bones or kidney stones. Basically, manage supportive of their ABCs, and that's about it. Transport them to the hospital as quickly as possible. All right, so an interesting panhypopituitarism. This is an inadequate production of the absence of the pituitary hormones to include adrenocortical hormone, which is ACTH, cortisol, thyroxine, which is T4, and your luteinizing hormone, which is LH. Also follicle stimulating hormone as well, FSH, and then finally growth hormone, and the antidiuretic hormone, ADH. The clinical presentation on this varies depending on the hormones that are lacking. Generally, this is an overall condition in which all the different types of hormones are inadequately produced, because your primaries are, as following. Your primaries are your ACTH, your TSH, your LH, and your FSH, and also your ADH. As you can see on this chart, let's make me disappear here real quick. You can see how important all of these are. People don't realize how important your endocrine and your thyroid system is and what all it does for us. It controls our body functions on a cellular level like you wouldn't believe. So it's very, very important that we have these in place in adequate levels. All right, so diabetes insipidus and steady. Unable to regulate the fluid due to the lack of aldosterone or ADH. It's some of the same characteristics as diabetes mellitus. It is not pancreatic pathology. Basically, the body is unable to regulate fluid caused by the lack of ADH, which is strictly over central diabetes insipidus, or the kidneys are unable to keep up and respond appropriately, which we relate to as nephrogenic diabetes insipidus. ADH causes the kidneys to retain water, therefore the lack causes an increase in urination, as we see as well in diabetes mellitus. One difference in DI and DM is the amount of glucose present in urine. DI, it's very diluted glucose, and DM, it's very excessive. So you can tell the difference between diabetes insipidus has very little glucose in the urine, where diabetes mellitus has a lot of glucose in the urine. Ultimately, dehydration and electrolyte imbalances may occur. Risk of water intoxication and hyponatremia is also possible as well. All right, so here's the comparison chart on 23-5. This is our last slide of diabetes insipidus and SIADH. It's the comparison. Pretty good chart. It gives you differences. I'd say the best way to go as far as diagnosing this would be the differentiation of the amount of glucose in urine. Most commonly, we don't test urine in the field, but if you work in a clinic somewhere, you may be doing this. All right, with that, I want to thank you for taking part. This has been a very long lecture. This lecture turned out to be 1 hour and 12 minutes. Appreciate your presence here and your patience. And we will see you next time. Be sure that you clock out to get credit for this lecture and take your Quizlet for this particular chapter as well. Have a great weekend.